Hello and welcome. My name is Hannah Sung, and I am moderating the symposium today. The topic is COVID's hidden crisis, moral injury in healthcare providers. This event is 2 hours long with a short break in the middle. I would like to begin by acknowledging the land on which McMaster University is located, which is the traditional territory of the Haudenosaunee and Anishinaabe nations, and within the lands protected by the Dish with One Spoon Wampum Belt. That wampum uses the symbolism of a dish to represent the territory and a spoon to represent that people should share resources and only take what they need. Toronto, which is where I am located today, is home to many diverse First Nations, Inuit, and Métis people, and is covered by the Treaty 13 and the Williams Treaties. I hope you can take a moment to consider the treaty territory you are on and what land back and stewardship of the land mean to you and your community. And in fact, I'd love to hear where you are this morning. Chat your location if you like. Just drop the name of your city or town. It's nice to warm up the chat that way. The chat is a space for you today, so please keep it respectful and on topic. This symposium is part of a larger project called Healthcare Salute. Thank you for your service, which is funded through PHAC, the Public Health Agency of Canada. And Dr. Margaret McKinnon, who you'll be meeting in just a moment, has been working with her team to gather evidence on the mental health impacts of working as healthcare providers during the pandemic. Data has been gathered using interviews and surveys with healthcare providers around the country, and the researchers will be sharing their findings today. Several Canadian researchers are joining to provide insight into risk and mitigating factors on moral injury, and you will also hear from healthcare providers who describe what they've experienced at work. And it goes without saying before we begin that we are very grateful to healthcare providers for the work they do today and every day. So some of what you hear today may bring up some emotions. That's okay. If you need to take a break, please do. Maybe step away from the computer, come back, get a glass of water, take a deep breath. There are resources that have been compiled and that are in the chat for you. Please take a moment to copy and paste them into a new browser or just take a screen cap so that you have these numbers and websites for your use. And with that, I would like to introduce Dr. Margaret McKinnon to the stage. Hello, Margaret. How are you this morning?
Good, how are you? It's nice to see you.
Same here. And so today the topic is moral injury and moral distress and why it is so important right now to understand these things. Can we start with some definitions? What is moral injury? What is moral distress?
Thank you so much, Hannah. And before we get started, like you, I'd just like to take a moment to acknowledge the healthcare workers across Canada and public safety personnel who have sacrificed so much throughout their service. This has been a sacrifice by healthcare workers, but also by their families who have also been impacted. And we very deliberately chose the term healthcare salute. Thank you for your service for this project. So we have the honor of working very closely with the Canadian military, and we often use the term thank you for your service and salute. We salute your service, and we want to salute that same service of healthcare workers and public safety personnel today and thank them and their families for their service and their sacrifice. In talking about the research today as well, I also want to acknowledge the people and organizations who generously funded this research. And so the research that we're presenting today from the Trauma and Recovery Research Unit at McMaster University, St. Joseph's Healthcare Hamilton, and Homewood Research Institute was funded initially by a grant from, or rather a contract from the Center of Excellence on PTSD in Ottawa, which is now the Atlas Institute, by a very generous donation from Homewood Health to Homewood Research Institute, by the Public Health Agency of Canada, and by the Canadian Institutes of Health Research. So we just want to take a moment as well to thank the funders who allowed us to do this work very early on and gather the knowledge and information necessary for the work that we're talking about today. So when we think about moral injury and moral distress, we can think back to the words of General Romeo Dallaire when he returned home from Rwanda. And he talked about the moral injury and moral distress that he and the men and women who he served with experienced in Rwanda. And so moral injury takes many forms, but one is the sense that one has either engaged in or witnessed events that violate one's moral and ethical values. And so for General Dallaire, he talked about being in Rwanda and being ordered to stand down by the United Nations and not intervene during the genocide and the slaughter that was occurring. And that was for him and for the men and women with whom he served a fundamental violation of their ethical and moral values. In the pandemic and the interviews that we've been doing, and others across the country have also been doing from other research groups that will also be here today, we've heard about, for example, when healthcare workers have had to, deny parents access to see a critically ill child because of no visitor policies. We've heard about the proning of older adults and turning over an older adult who really doesn't want care, but their substitute decision maker has insisted upon it, and how painful and difficult that can be, that proning, which takes 7 people. People talk about, these things that had to be done in many instances during the pandemic, but that for people it was really difficult because it touched upon or had a sense of betrayal of their moral or their ethical values, or they witnessed situations that they felt were a violation of their moral or ethical values, and were powerless to intervene. We also heard from General Dallaire when he returned home about the betrayal that he and the men and women he served with felt that they had experienced. And they talked about being ordered to stand down and the impact that that had on those who were there to protect, so the citizens of Rwanda, and also on the Canadian Armed Forces, where he said this was a betrayal by an organization that had a duty of care to the people of Rwanda, and also to those who were serving within Rwanda. And here we've heard healthcare workers talk about in this context, but for example, being provided with, very light masks at the beginning of the pandemic. I even saw a video where I saw nurses being instructed to wear Kleenexes while they transported bodies over their faces. Yes, and so many people serving in healthcare at the time and continuing on have felt that with that perhaps there was not enough preparedness for a pandemic in some situations. Also that they felt that the organizations or individuals who they were serving with had a duty of care to them, and they felt that that duty of care was not met, or to patients as well and families throughout the country. And so this really is the concept of moral injury. So the notion that one has engaged in or witnessed or been powerless to prevent events or incidents that violate one's moral and ethical values, or that they have felt a betrayal by an individual and organization who they feel has a duty of care to them during the pandemic.
There's a lot of complex context there in terms of understanding moral injury and moral distress. I hear that on an individual level, it's about a violation of your own moral code and the stress that that entails. And I wonder, when you use the term moral injury, can you describe how it is an injury? Can you tell us more about that?
So moral injury, I would say, is something that exists in itself. It is associated with post-traumatic stress injuries, with depression and with anxiety, but it's separate. It has a different presentation. And when a moral injury occurs, what we often see is an increase in, we can see increases, for example, in suicidality, difficulty functioning at home, at work, at school. We might see an increase in symptoms of depression, anxiety, post-traumatic stress disorder, difficulty sleeping and insomnia, increased substance use and abuse. And so really this is a form of injury. We always talk about physical injuries, but we don't talk as much about psychological injuries. And this is a psychological injury that has occurred to an individual as a result, again, of their service and their sacrifice.
Thank you so much for that, Margaret. I know that we're going to be hearing from you again later on this morning. First, we are going to hear some findings from your research team. Did you have anything you wanted to add just before we move on?
Nothing to add, but I would just again like to thank the individuals and organizations who sponsored this research. So again, the Public Health Agency of Canada, the Homewood Health Incorporated through the generous donation to Homewood Research Institute, the Center of Excellence on PTSD, and of course the Canadian Institutes of Health Research. This work would not be possible without them. And I think it's work that really we need to do in order to best support healthcare workers, public safety personnel, and their families over this time. So thank you, Hannah, very much.
Yeah.
And thank you so much for moderating this session. We're really grateful.
I'm just so happy to be here and to be learning for sure. And so speaking of learning, we are going to go now to a short presentation from a member of Margaret's research team, Yuanxin Xu.
Hi everyone, thanks for having me here today. My name is Yuanxin Xu, and I had the pleasure to work with the Trauma and Recovery Lab led by Dr. Margaret McKinnon over the past year and a half. I'm really excited to be here to share some of the results we found in a scoping review we started the summer of 2021 and we completed earlier this year. So it's on the potential circumstances associated with the moral injury and moral distress in healthcare workers and public safety personnel, and this is specifically during the pandemic. So I just want to warn you, this is a fairly short presentation, so there may be some details on the slides that I won't be directly speaking to, but they'll still be there for your reference. So we knew that healthcare workers and public safety personnel were encountering many morally and ethically challenging situations during the pandemic, and we really wanted to see what was out there in the literature in terms of the circumstances that may cause or may potentially lead to moral injury and moral distress. So this is the research question we used to guide our review. What are the shared and unique circumstances of healthcare workers and public safety personnel during COVID globally that are potentially associated with moral distress and moral injury? So here are some of the abbreviations I'll be using throughout the slides. And I just want to direct your attention to the last one there, PMIDE. This one stands for potentially morally injurious or distressful event. And we use this term to kind of look at moral injury and moral distress as a collective. Our goal wasn't really to try to delineate between these two terms, so we thought it would be a better idea to look at them together and to see moral stressors more holistically. So here's a brief overview of our methods. We started our search the search of our articles in the beginning of 2020, and we went until May 2021. And we included any article that talked about healthcare workers or select public safety personnel populations in the COVID-19 context, and they also focused on circumstances that might lead to moral injury or moral distress. So that's definitely a bit of an oversimplification, but you can find the more detailed methods online. And from that search, we identified approximately 1,400 articles, and in the very end included 57. So before I get onto this map here, I just want to say that out of the 57 articles, all of them were primarily focused on healthcare workers. There was only a very small subsample of public safety personnel in 6 of those articles, but they were also aggregated with the healthcare workers as well. So it's really hard to differentiate those results. So for the most part, the results I'll be talking about today, they're primarily relevant to healthcare workers, but that's not to say that they're not relevant to public safety personnel as well. We just need to do a bit more research. So this here is the world map, and we have different parts shaded in just based on the included studies and the populations they studied. So you can see that the majority of articles focused on North America, and there were some in East Asia and South Asia, some in Europe, and a few others across the globe as well. And in terms of the results we found, so after collecting all the relevant data and coding them, we were able to come up with the 6 overarching themes that describe the types of circumstances associated with potentially morally injurious or distressful events. So the first one here, it had to do with the risk of contracting or transmitting COVID-19. There were 34 articles included, and we saw that some articles spoke about how this is particularly relevant for healthcare workers who were more vulnerable to having severe infection or those that were living with vulnerable populations. The second one here, the inability to work on the front lines. This one really speaks to some of that guilt that healthcare workers faced when they didn't have the same level of risk or exposure compared to some of their colleagues who were on the front lines. And this also included people who needed to quarantine, and then there was that additional workload that was placed on their other colleagues. The third one here is the provision of suboptimal care, and this one really just refers to healthcare workers not being able to provide that same level of care as they would have liked to. And this was partially exacerbated by all of the uncertainty during the pandemic, but also by the infection control measures that created distance between the providers and patients, as well as the visitation policies that made it difficult for family gatherings. The fourth theme here It refers to care prioritization and resource allocation. So this really refers to all those tough decisions healthcare workers had to make when resources were scarce and there was only a limited capacity to do what they could. This was especially tough when it came to critical care resources. The fifth theme here, it refers to healthcare workers' perception of that lack of support and unfair treatment by their organization. So some of the ideas that were in this category included not having adequate benefits or protection for the workers, as well as just a lack of communication and transparency about the whole situation. And the last one here, it's the stigma, discrimination, and abuse that healthcare workers faced. Some of the articles included in this section spoke to how healthcare workers, they were viewed as virus carriers by their friends, colleagues, and even their family. Some experienced discrimination by their community, and others also reported acts of violence by patients and other families. So when we look at all these themes and the articles that were included in each in terms of where they're geographically located, for the most part, all of these themes, apart from one, they are fairly globally spread. And this was especially true for the risk of contracting or transmitting COVID-19, as well as the perceived lack of support and unfair treatment by the organization. So the only exception was the category of stigma, discrimination, and abuse, where there was a lack of articles from North America. But this does not mean to say that this doesn't happen in North America, but it's more likely due to potential underreporting of some of these issues in the context of moral injury and moral distress. And we definitely need to do more research to get a better understanding of the severity of those experiences and the context. So with that concludes the presentation, and I just want to say thank you to Dr. Margaret McKinnon, as well as everyone who contributed and really made this review possible. And thank you guys so much for listening today. It was a pleasure to speak with you all.
Thank you so much to Yan Chin, who we'll be hearing from in one moment. First, we're going to hear from another presentation from another member of this research team. It's from Andrea Brown. So let's watch.
Thank you for inviting me to speak today. My name is Andrea Brown, and I'm a research associate in the Trauma and Recovery Research Unit at McMaster University. Since September of 2020, we have been collecting information about moral injury in healthcare providers across Canada. And what we're finding is that healthcare providers are in fact experiencing moral injury during the pandemic. Moral injury has been called the signature wound of service. Although this was originally brought forward for military members, we also believe that it applies to our healthcare providers. In our very first webinar in the Healthcare Salute series, Kim Ritchie and Andrea D'Alessandro Lowe gave some information about the types of events that healthcare providers have identified as morally injurious or morally distressing. These include witnessing patients dying alone. At one point during the pandemic, family members weren't allowed to go and have end-of-life time with their loved ones. And during this time, healthcare providers had to watch their patients dying alone. And this spanned the age ranges of very old to very young. Also, providing invasive care, which is perceived as futile and prolongs the suffering of their patients. Increasing workload and decreasing staff, which is something that's impacting our healthcare providers even today. Bullying, violence, and divided opinions, as well as a disconnect between frontline staff and the organization. So we know the types of events that are being identified as morally injurious or morally distressing by healthcare providers, but we're also wondering, what are the impacts? In particular, we're wondering about post-traumatic stress, depression, anxiety, stress, dissociation, substance use, and resilience. Are these things that are also impacting our healthcare providers? So in order to understand this better, we had a survey that was open from September of 2020 until September of 2022, and it was open to healthcare providers across Canada to complete. The bulk of our participants were nurses and respiratory therapists, but we also had many other healthcare providers complete, including occupational therapists, physicians, those in dentistry, long-term care, and mental health. And in total, we had nearly 700 people complete the survey or partially complete the survey. 80% of our participants identified as being female. The bulk were from Ontario, living and practicing. We also had nearly 10% from Alberta and British Columbia. We did have representation from across the provinces, although we didn't have representation from the territories. And nearly 70% of our participants identified as having European ancestry. The first question we really wanted to know is how many of our participants said that they were experiencing these events or these situations that they would define as morally injurious. So we asked them a question asking if they had been exposed to 3 types of events that goes against their moral codes or values. So these are events in which they did something or didn't do something that went against the moral code. They witnessed somebody else doing something or not doing something that went against their moral code, and then being directly impacted by something that somebody else did or didn't do that went against the moral code or their values. And what we found is that 70% of our participants were exposed to these types of events that went against their moral code or their values. And 67% of our participants said that they experienced these events in 2021. And 72% of our participants in 2022 said that they had experienced these events this year. And that was between January and September. So we know the types of events that are being defined as morally injurious. And we know that 2/3 of our healthcare population are experiencing these types of events. So then we wanted to know, how is it impacting them? So we asked questions in our survey, and what we found was that those who perceived greater moral injury also experienced greater rates of depression, anxiety, stress, post-traumatic stress, and dissociation. These are at a statistically significant level. But we also found that those who had greater perceived moral injuries also used more substances in order to try and cope. So this includes increasing alcohol use, cannabis use, and other recreational drugs. Although this wasn't statistically significant, there was a positive correlation between the two. And what we also found is that those who had perceived greater moral injury also had decreased resilience. So this is the feelings that they could cope with the stresses and that they could bounce back with the stresses. So we know that what the morally injurious events are. We know that 2/3 at least of our healthcare population are experiencing these events, and we know that it's impacting their mental health, their coping ability, and their ability to bounce back. So together with our collaborators, we have created some recommendations for healthcare organizations and leaders. And it begins with listening and understanding healthcare providers' experiences and the impact these experiences have had on healthcare providers and their family, because the impacts go home with them. Asking healthcare providers questions about what they need to perform their roles and improve their mental health, because healthcare providers know what they need more than anybody else. And then providing access to appropriate supports for healthcare providers. So taking what you've learned when you're listening to their experiences and understanding what it is that they need, and then providing them with those supports. The supervisors and the management in these organizations are also under a lot of stress. They have to balance the needs of the healthcare providers and the organizations to make sure that the services are being provided for our population. So another recommendation we made is to provide supervisors and management with resources and training to support healthcare providers' mental health. And finally, we recommend to establish evidence-based policies to guide ethically difficult decisions while on the job. Healthcare providers have to make life and death decisions, and they said it would be helpful if they had policies to help guide these decisions, and that these policies were based in evidence. So to summarize my very short presentation today, we know that healthcare providers are experiencing moral injury, and we also know the types of events that they are saying are morally injurious. We also know that these moral injuries are impacting their mental health, their ability to bounce back, and substance use. So what we are going to do is to continue to conduct research to identify interventions and by the long-term impacts of these moral injuries. Thank you very much.
Thank you so much, Andrea. And I have a feeling that there were probably many people in this webinar who are nodding along to the observations and the details and the recommendations that you just shared with us. So I would like to invite Yuanqin and Andrea to join me for a quick debrief of your presentations. Your presentations were filled with detail, and I would like to just go very big picture, if I may. And first, I'll ask you, Yuanqin. You showed us the map of all the various places from which you drew your research. Did you find important similarities between your findings globally and the data in Canada?
Yeah, no, for sure. And thank you for that question. I think that was actually a big part of why we started the review. We wanted to see if what we're seeing in Canada was really happening across the globe as well. And although most of the articles were more based in North America, I think we did get a glimpse of what it does look like globally. And I think like when you look at the themes we found and the other information that we gathered on Canadian healthcare workers through the interviews and the surveys, they're basically saying the same thing, but they're just organized a little bit differently. And I think two of the really big similarities is probably anything that's related to patients and not being able to provide the optimal care that they used to be, whether it be not having patients that had to die alone because of visitor policies, or other limitations to work because of increased workloads or changing protocols, or simply just witnessing like patients who were receiving care that healthcare workers may have felt was futile. I think that was definitely a big similarity between what we see here as well as in the review. And I would say another big area was had to do with like the organizations, and that just perceived lack of support or sometimes even betrayal that healthcare workers felt when there wasn't adequate PPE, adequate staffing, and just that disconnect that sometimes there was between the frontline workers and the organization.
Well, I find that so interesting that you found those key similarities, because as someone who doesn't work in healthcare, I would think that depending on your region, depending on the type of healthcare system, that there would be some real specificity about the work that happens. But in fact, there were certain experiences that healthcare workers had just across the board during the pandemic.
For sure. I think like when you look at big picture, I think it's pretty much you're looking at the same things, but maybe if you like zoom into Canada or different parts of the world, the severity or extent of certain experiences, that might differ. But I think for the most part, we're seeing that healthcare workers, they were experiencing moral injury, they were experiencing moral distress, and there's definitely a lot that can be done there.
Thank you, Yuanqin. I would like
to
move over to Andrea. Please do, yes.
Okay. So during Yuanqin's presentation, he said that the one area that wasn't as supported in North America was the stigma, discrimination, and abuse. But I think that might be because of when those publications took place, because our research is actually finding that in the last year, that is a moral injury that has come up more and more in our conversations with healthcare providers. So it could just be that the research ended and was published towards the end of 2021. So that means it was submitted before that. So in the last year, it actually has risen.
Yes, it's interesting because in your presentation, you said, Andrea, that you were looking at research, or your team was conducting surveys that go all the way up to just a couple of months ago, until September of 2020.
End of September, right?
Yeah. So I would love to ask you, Andrea, again, very big picture, why do you think it's important to understand how moral injury specifically is related to mental health when it comes to healthcare providers?
I think the big thing, Hannah, is that understanding the impact of moral injury on healthcare providers will help us to provide them with the supports that they need and what types of supports that they need to have. Healthcare providers play a vital role in our society, and it's one of the things that Canadians are always so proud of is our healthcare system. Our healthcare providers who have always made life and death types of decisions and have always been in these types of situations. Something about COVID-19 is different, and it's intensified everything. And so we now know that they're facing moral injuries. We know how it's impacting them. So we as society, at the government level and at the organizational, understanding this, can start to implement the behaviors and the skills and supports for our healthcare providers to help them while they're helping us.
Mm-hmm. And I'm glad to see that there are some questions that are coming through the chat. So I will say that there are probably too many to get to them all, but please keep them coming and I will get to as many as I can. So I'm just going to choose one here for you both, Yeoncheon and Andrea. Karen is asking, when gender-based analysis was applied to your research, were there any important variations in findings based on specific occupation and or sex and gender of the healthcare provider? Would either of you like to speak to that?
At this time, I have not run the analyses on the gender-based analysis, but I would reiterate that 80% of our population identified as being female, so it'll be a small percentage that identify as male or non-binary.
Thank you. And I will ask one more question. What are the next steps in terms of interventions? Any suggestions and or recommendations? I know, Andrea, that there were several in your presentation. Maybe you can go into some of them in detail.
Sure. So one of the things that's come out of our research is that we've made some recommendation, and I know that Sangeeta has put a link to these recommendations within the chat. In addition, the funding that we're receiving from the Public Health Agency of Canada, we are creating some psychoeducational programs that will be available online. It includes some training for trauma-informed care it can be used by healthcare providers in their work, but it can also be for people who are supporting healthcare providers and understanding that everybody has traumas, and when we're working together, these traumas are impacting people regardless. So when you're dealing with somebody, realize that they might not always be in the same situation that you are because of what's happened in the past or what's ongoing at work. We're also creating with the University of Alberta some psychoed programs, online programs on what is moral injury. And then we've also created one on PTSD, stress, and that will help people to understand. Let's say that you're a healthcare provider and you really don't understand why you're not sleeping well. And I'm sure that healthcare providers do understand this, but it'll help to go in and say PTSD and stress and moral injury, this is how it affects your body and this is why you're feeling this way. And we will also connect you with some other information that you have. And there are also supports available online that we will connect you with.
So it sounds like the experiences that healthcare providers may be having, it's good to have the language and the backup and the evidence to show that healthcare providers need help and that these injuries affect the ability to do the job.
Right. And remembering that healthcare providers are helpers. They're always helpers, and they often put themselves lowest on their list of who to take care of themselves. But it shouldn't just be on healthcare providers to take care of themselves. We as a society need to do what we can to support our healthcare providers. The government needs to put in the laws and the regulations to support our healthcare providers, and the organizations need to do that too. So let's take the focus off the healthcare providers taking care of their mental health, and let's put it on everybody to support our healthcare providers.
Absolutely. Well, Andrea and Yeoncheon, thank you so much for your research and your presentations. I really appreciate it.
Thank you, Hannah.
Thank you.
Thank you. And while we are speaking about healthcare providers, why don't we speak to healthcare providers? We have a panel of 3 people who have very generously given their time and are about to share their experiences with us. I'd like to quickly introduce you to them. Michelle Johnson, if you could join, Krisha Fortuna, Jennifer Kwan. Michelle and Krisha are nurses. Jennifer is a family doctor. And if you're on Twitter, if you were on Twitter during the pandemic, you know Jennifer has provided a lot of information there for lay people such as myself to understand COVID data. So I want to ask all three of you about what you're hearing today about moral injury and moral distress, and whether these definitions and these observations speak to you when you think about your day-to-day work. But first, can I ask you just very quickly in 10 seconds to tell us, what is your job and what is your favorite thing about your work? Maybe Michelle, I'll start with you.
Okay. So I'm a nurse of 32 years in a hospital in downtown Toronto. And there's sort of three things I really love about my job. It's this kind of collection of like the science, hands-on, critical thinking, and this empathetic opportunity to sort of meet with a stranger in distress who I can reach out with my heart and reach theirs and have a moment that's like, it's an incredible privilege to be able to do that. And the other thing is this kind of incredible support I get in my whole life, all aspects of my life that I get from my colleagues. Like working with people who are caregivers is an incredible privilege because we care for each other in the same way we care for the public and people we've never met. We care deeply for each other, and that's a pretty wonderful job.
I love that description. Thank you so much. And I'll also just mention, Michelle, that I think your microphone is rubbing on a little something. I don't know if you want to just, check that out, but you sound great. And maybe I'll go to Krisha now. Can you tell us about your job and what you love about it? Krisha is not here at the moment. I'm sorry, I introduced Krisha, but my view of the Zoom is very complicated. So I could not see that she's actually not here at the moment. She is here. As you can see from the chat, you have to have a moment like this in a Zoom. I'm not sure if we can get Mike to help out with bringing Krisha into the panel so that Krisha can speak with us. But maybe for now, I'll just go to Jennifer. Can you tell us a little bit about your job and your favorite thing about it?
Thanks, Hannah, and thanks everyone for joining us today. I'm a family doctor in Burlington. I do love my job. I love my patients. It is such a privilege to care for people and their families and kind of develop these long-term relationships and get to know them over time. It's both rewarding and heartbreaking because sometimes, we do see things happen to people, but it's such a privilege to be there to help fix things that we can fix and to, hold people's hands like figuratively when they are going through illnesses and help people with their health over time. So I really do love my job, and despite some of the, moral distress that we experience, it is still a very great honor to be a family doctor.
Thank you, Jennifer. And Krisha is joining us now. I would love for you to tell us in 10 seconds about your job and what you love about it.
Hi, everybody. Sorry about that. What I love about my job is getting up to see patients every day, helping those who need help, who they might need something like a flu shot, and then it will change their day. It's about touching, it's about speaking to your patients and really connecting with them. In some ways you can to just help. I don't know, it's just always an innate feeling towards in my line of work. It's just, I've always loved helping, and I felt like I was put in this world for the purpose of helping somebody. And it's just interacting with people every day and making a difference. That's how I believed, how I was put in this world, is to help people day in and day out, no matter what.
Thank you, Krisha. And I know that you're a nurse and that you work with people who are, I believe, newcomers to Canada at the moment.
Yes.
That's your work. Mhm.
Correct. Yeah. I currently work with newcomers and refugees coming into Canada. So I provide mostly primary care, help them go over like helping them with resources and working through a lot of barriers and really advocating for patients, because how come this patient can't get what they need in order for them to be healthy, however these people can. So, and what I've noticed is there's a lot of racism involved, and there's just a lot of barriers for patients, especially coming into Canada. And myself as an immigrant, I know exactly how I transitioned over here, and how challenging it was. And oftentimes that's how I've been connecting and able to empathize with patients like that, because they're also struggling. And then I think that's why I have chosen this field, is because in some ways I'm doing more than just just cleaning up a wound or whatnot. I'm actually doing something for them, for their future.
Mhm. And it strikes me as you're speaking that you work with people who are in a vulnerable situation because they're new to the country and they face many barriers. But I guess all healthcare workers come in contact with people who are in a vulnerable moment because they need your help. And Krisha, if I may start with you in terms of experiences throughout the pandemic and doing your work. Earlier in the pandemic, you were working in long-term care. And I would like to know, what did it feel like at first to be managing your nursing staff, especially when it came to outbreaks of COVID in the facility?
So while I was working in long-term care, I think that all of us, we were all quite scared. For us, it was kind of a invisible dooming cloud coming in, and soon as you know it, you just get it, and then it spreads like wildfire. So for us, it was really important for me to ensure that staff are well protected, and they always, because you have to think about it, they have people to come home to. They have family, loved ones, children, grandparents, and these are the people who rely on them. There's a reason why they come out and do this job every day. So for me, I've had one experience where I had to practically raise my voice at the staff because we were in an outbreak. And in an outbreak situation, you really need to be considerate, and you need to be very cautious, and you need to be on your high alert, because at that time, we didn't know what COVID was. Like, we didn't have all these informations, and how widespread it could be, and how it travels through airborne, and what kind of protections do we need. So for me, I had to stand up for them, because I had to tell them, listen, you know what? I need you guys to protect each other. This is the only way we really can come out of this. You look out for me, you look out for her, and you look out for him, or you look out for your next teammate. That is what is all about. And I think I was reprimanded for the fact that, like, I shouldn't be I shouldn't be raising my voice at staff, but I thought at that time I was being honest, and I really laid out the reality that, it could be any of us and who will get sick. And then, God forbid, it spreads to other family members. Like, my dad was diabetic, or is a diabetic. I was very scared. Yeah. So that's how some people might not like my approach, but I felt that I had to make that very clear, that safety was very important.
I can definitely hear that emotions were running high, because when you say you raised your voice, you were stretched to that point where you needed to do that. Um, Michelle, I would like to turn to you for a moment because you are also a nurse, and you mentioned that you have been in nursing for 32 years. I feel like if you've been doing anything for 32 years, you've probably seen it all, but COVID was unprecedented, as we know. Were there any firsts that you witnessed at work during the pandemic?
Yeah, thanks, Hannah. There certainly were. And just to start out with, I want to just say thank you so much to the researchers who've done this work. It's actually touched my heart so deeply. I feel a little I'm really touched to have what I've experienced and the emotions that we as nurses carry, to have it received so wholesomely by the researchers and reflected back has actually really touched my heart. And I'm a little bit like, oh, this is kind of exciting to realize that all that we have done is being so validated. And that's really wonderful. So thank you for that. And what I would like to say is what I saw for the first time was sort of the impact of this moral injury and moral distress, and the sort of way that COVID tipped things. When COVID arrived, we didn't realize how deeply us nurses depend on each other. We are a resilient collective. We are a network of caregivers who care for each other and care for our patients. And it's a real, I'm doing this with my hands because it's a way to sort of articulate how we're greater than the sum of our parts when we are together. And when COVID came, they gave us these flimsy little blue surgical masks, and they only work if we all wear them and we stay 6 feet apart. And that imperative to isolate left us alone, and our distresses became individualized. Prior to this, we had always come together. I could find a colleague and say, hey, and suddenly we were individualized. We weren't a collective, we weren't together. When any of us experienced the fear, the anxiety, the sorrows, when we were in a situation of overwhelm, we were alone with that feeling. And I had never before seen nurses breaking down, isolated. We've all cried in our shifts. But to find nurses sobbing in utility rooms and in quiet corners, it stood in a stark contrast to SARS, which came 20 years ago. When it came, we were all rapidly given N95 masks in the hospital, and the whole city was scared of us, but we knew we were safe because we had our N95 masks, and we knew they would keep us safe. And we were able to gather, and we were able to support each other. And the sense of betrayal that I feel because we've been denied proper PPE, because it was, here's your blue mask, stay apart. It has fractured this incredible network that nurses depend on professionally and personally. We come to work for 12 hours and we support each other so that we can also go home and still be as good of people as we can be. And I personally feel sort of, I'm quoting Margaret, I wrote some of her words down, which is speaking like a guilt and shame in the difficulties of and the moral distress of our failure to our collective selves as nurses, and allied health professionals, including doctors, in our stuff. And there's been no time, energy, or focus for us to come back and support each other. And this is a big, what's the word? This fracture is really detrimental to novice nurses, to newcomers to the profession. It's a really vulnerable time, and if they don't have this, I don't know how they'll stay. And the healthcare system depends on them. So I really appreciate the urgency that you researchers are putting into looking at this. It's really, really, really wonderful. Thank you.
Thank you, Michelle. I want to say that I can feel the emotion, and I was doing a lot of deep breathing as you were speaking. And I invite everyone listening who's experiencing your story right now to take a deep breath, or many if you need, and Michelle, what I hear from what you're saying is echoes of the fear that Krisha was talking about, the fear in the workplace, and then on top of that, the isolation, which is so debilitating for people who work as a team and who need to work as a team. I would like to turn to Jennifer now. You work as a family doctor, and I mentioned off the top that you also provided COVID charts every day on Twitter, which was very useful for people who were fearful and who wanted more information or to know how to understand the information. I know you did that Twitter work above and beyond your regular job, and healthcare professionals have been going above and beyond on an individual level, well, since before the pandemic, but also have been asked to do that during this time. What has that been like in your experience, that constant kind of above and beyond feeling?
Well, well, thanks to Michelle and Krisha for like articulating it so well, that kind of feeling, especially early in the pandemic when like there was no vaccines, right? We didn't even like have masks at times. Like I remember even in my clinic, we were like trying to order more masks. We were running low. Like how can we protect our staff and continue to see patients? But like our supplier, like our expected delivery date kept going back like months. So it was that kind of fear that we all felt initially. And I think everyone tried to pitch in whatever way we can, like going beyond what our regular clinical duties were. For myself, I thought, oh, like I can share information. Yeah, it's not part of my job, but I felt like that was another way we can all work together. And I think early pandemic, we all did that. Like we all kind of thought about what we can contribute and have a collective effort to, protect our patients, protect our families. So I think that feeling we all definitely shared. And even now, I think the struggle is that we're still constantly adapting to the changing environment. Now, like COVID's increasing again. Now we have other respiratory viruses like RSV. There's just so much going on. The children's hospitals are struggling. We're still trying to keep, our PPE supplies up and trying to protect our patients. For example, we're still doing like outdoor visits in the parking lot for people who have like respiratory symptoms, but the weather's changing, so we have to adapt to that. And it can be difficult because when patients are sick and struggling, sometimes they're also very upset, and that can, affect us and the staff if people are, upset at us. But really, we shouldn't be upset at one another. We should still continue to try and have that kind of collective sense of tackling the pandemic together, because really, I think that's what everyone's grieving. We're missing our pre-COVID times where we didn't have to have this looming cloud, like Krisha said, over our heads, and just live our lives and be normal. But now that we know it's been so long, we just never know when or if that will happen. We have to continue to work together and adapt and support one another through this.
Thank you, Jennifer. And you mentioned many things, but one of the things you mentioned is that people are upset. And I saw some data the other day. I don't know how they are measuring it, but there's more rudeness. And I think that it probably, especially as people who deal with the public, you probably don't need a study or research to show you that. I'm just wondering if any one of you would like to tell us about what it's like to be the helper, as we've talked about, and all your energy goes into helping on the job, and yet it is such an exhausting job for all the reasons that you have outlined, needing to go above and beyond, needing to really have part of your mind go to PPE and thinking about that or the lack thereof, thinking about handling patients who are upset, and there are different types of exhaustion too. There's physical exhaustion, but then there's mental exhaustion. And I'm wondering if anybody would like to jump in and just talk about how they handle that.
I can probably provide an example. I there's not really a way to handle this huge stressor. I think how I managed to work through it, and because like when I was in an outbreak situation, I was pretty isolated. I was away from my family members. I had to live in the hotel. You're by yourself. You essentially get up to go to work, you prepare yourself, and I think somebody read in the comments that, they used to cry in the car going in. That used to be me. That used to be how I managed to deal with it. And then, you're worried about your other colleagues who are also sick. But the only thing you have to do is like, you have to get stuff done. Like someone has to take care of these people, because who else is going to take care of them? We have this like moral thing where we don't leave anyone behind. We are in this position of, power, and these people are so helpless, and, you treat them like family, they're part of your family. You don't leave anybody behind. So what do you have to do? You have to get up, and then you have to do it. You have to pull yourself in bootstraps, and then you have to make a strong face for everyone else, because the next person you're looking at, who they're also just feeling the same way as you are. They're also just, breaking down inside, but they don't want to show it because they're scared that they're going to be either stigmatized or be labeled or whatnot. But they're also kind of like, I don't want to break down at work. I'm not that type of person. They have a lot of pride in their jobs, and they're really dedicated. So yeah, I remember crying because I couldn't, care for somebody because I spent so much time on another patient. And it's true what the research shows. It's you're never supposed to be in a position where you have to be God. You shouldn't be. You shouldn't have to choose this person lives and this person dies because you're only one nurse for 32 patients and everyone's COVID positive, and you only have a handful of staff, and most of the staff are scared for their own loved ones. So I remember meeting just the PSW who showed up for her patients, who've known them for years and years and years. And then we cry in the back and we say, you know what we have to do? Like, we have to take care of these people. Let's get stuff done. Let's get, if we miss some stuff, what can we do, right? Let's just try our best, because we are the only one who can help them. And then they can't even help themselves. And you have family members calling phones and whatnot, and you can't even use the phone because they're all full of messages. And as soon as the one phone rings, it's like, hi, did you hear about my family member? Did you hear? I've been calling everywhere. And I'm like, I'm so sorry. This is you can't provide updates. Yeah, it's that's kind of what you have to do every day. Is like a war. You have to put on your gear, you have to put on your mask, you have to put on your face shield, you have to be prepared, like wearing PPE all the time. You're gonna have your nose marks, and then like you're gonna get severe headache because of all like the Hasbro has provided you with rubber band and like a plastic shield and stuff. Though, like, and you're like, is this COVID? Is this just a headache, or is this just the face shield? And yeah, you kind of have to. Sometimes what made me feel better was that looking back at patients when they were like at their best, when they were like laughing, they were just joking around, or they did some silly thing, or their family members came and visited, and how they were reacting. Yeah, and it's true what Michelle said. It's really about camaraderie, right? And then this pandemic kind of made us feel more isolated and really fend for our own. And it's true. Like, you go in utility closets. I went to the chapel. I cried. And then I was praying. I was like, I hope I don't get it. And, I hope no one else, but sorry, I monopolize the time. If anyone wants to go, go.
Never say sorry. Your stories are so important to us.
Yeah.
And Michelle, I saw you nodding a lot. Is there anything you wanted to add?
Yeah, and thanks, Krisha. You've captured it. It's for sure what we deal with. It's this. I would like to just put it into a bit of context because of my elder status in the profession. I remember when it was a really honorable, not frantic, human, I'm going to even call it a gentle profession. In 1990, when I graduated, we had only begun the defunding. Defunding is said to have begun somewhere in 85, 87. Our healthcare system has been defunded for 32 years that I've been there. The impact of consistent progressive defunding has come at the expense of, and I'm a bit biased and I'm sorry, but nurses. We are the bulk physical workers of our healthcare system. We are the backbone of every hospital. If you need a doctor, you go to a doctor's office. If you're in a hospital, it's because you need a nurse. And we have defunded, we as a province have chosen to defund healthcare for 32 years, and it has brought all of us to the brink. The system now depends on each nurse working full out and to an exhausted state that I have never seen before. And it is a malignancy that I think jeopardizes the future of our healthcare system so fundamentally, because nurses are fleeing because they have reached their limit. We are all deeply exhausted. And what happens with deep exhaustion is mistakes happen. The moral injuries that do happen in distress because we've made mistakes are real. We don't sleep very well at night. We arrive, when someone hears a nurse works 12 hours, it's a lie. I'm at work for 13 hours. And our government has betrayed us by Bill 124, and our unions haven't been able to mobilize any action to be of benefit to us. And I just feel like a real threat is looming at how our hospitals are going to function, and our healthcare and our nursing homes, when nurses begin to fall because it's too much. We can't. We're done. We're breaking. It's a great urgent grief and fear of mine.
I hear so much, Michelle, in what you're saying that matches with the research that we have been hearing about. I hear the sense of betrayal, organizationally speaking. I'm wondering if there is anything else that anyone on this panel has heard about in terms of the definitions of moral injury and moral distress and the research findings. Was there anything else that really struck you as fitting with your day-to-day experiences at work?
I guess one thing I wanted to mention is at the end of the day, with this defunding of the healthcare system, impacting all healthcare workers, and at the end of the day, it's the patients that are going to suffer, right? And sometimes we don't see it it's not as immediate, like when you watch someone get COVID and get really sick, which is very devastating. But sometimes there's these kind of long, slow burning kind of fires. So for example, I have patients that would get like a breast lump, and then they have to wait for imaging, and they have to wait for biopsy, and they have to wait for results, and then they have to wait for the specialist to see them to find out whether they need surgery or chemo. And it's so traumatizing to the patient to have all these waits because the healthcare system is so overwhelmed. And these are kind of stories that you may not hear as much because it's kind of a more slow, chronic problem that keeps getting worse. for example, pap smears now, it takes like 4 months for a result. And that's, what if we're missing something? What if there is something abnormal that needs to be followed up on? And we're just not even getting results in time. So it's hard because these things are not as visible, but patient care is impacted. And when things are delayed, the diagnosis is delayed, treatment may be more invasive and aggressive because the cancer is worse. So I think that hopefully, maybe, if we can continue to advocate for our professions and for proper funding of the healthcare system, we can avoid a collapse. But it's not looking great in terms of the trajectory right now. And it's just very sad to see how a lot of the weight is placed on our shoulders when we really need the government to step in and make things right.
I'd like to jump in if I can now with a question from somebody who is here listening. Her name is Tracy, and she says she manages a 31-bed unit. I am at 48% staffing. My staff are at the breaking point. So this is what Michelle is describing. And Tracy says, I am seeing toxic interactions between our core staff and new IEN. If someone wants to explain what IEN means, I'm sorry, I don't know. But Tracy is saying she needs help. I've been a nurse for 30 years. Is there anything I can do to help all my staff? This is a very big question, but if there's anyone who, Krisha or Michelle or Jennifer, if you have a piece of advice for Tracy, she would like some advice.
I wish I had advice. I wish I knew the answer. It's that your staffing levels are not rare to run with 50% of your full-time lines vacant and no one to work those. That's normative now in healthcare. What that means, if you don't know what that means, it means you work short. And if you work 10% short, arguably each nurse does 10% more work. If you're 20% short, you're doing 20% more. 30% short, so her unit's running at 50% short. That's not surprising to me. That's probably where most of our emerged systems are at. And at that rate, the nurses who are coming on are working 50% more because there's not fewer people. Our population has grown while our funding has shrunk. So I think being a manager who cares and can hear and can do their very best to support and can recognize how everybody who does show up tries their best and works their hardest. I really appreciate when my boss says to me, Michelle, thank you for coming to work. Thank you for showing up. Thank you so much for staying late. Thank you for, for everything you do. It is pretty important to be thanked. So that's like the smallest thing I can suggest. And I think, Tracy, you're not alone. There's every manager, every nursing unit manager is dealing with this identical problem, and the ability to affect an improvement is really, really going to be difficult because what I see is the fracture when she speaks of senior nurses sort of aggressive at each other. There's a real fracture of relationships, and this kind of what I described as this kind of thing, we used to stick together, and now I've done it. I've snapped at my fellow senior nurses. I've snapped, and we now isolate just so that we can self-regulate, and we used to co-regulate, and now we self-regulate, and we've lost an ability, we've lost our way to find back relationship when that's fundamental to how we get through our days. And without that, we can hire new nurses, but they don't stay because there's not a network of support for them. They are even more isolated and more afraid. And it's like a problem that's like a snowball going down a hill. It's getting bigger and bigger because as people leave, there's more work. As there's more work, there's less support. As there's less support, there's less processing of the injury. That's part of our job. Moral distress is part of our job. It's part of the water we swim in. Like, there's just no way you can be a nurse and not have experienced this. It's just COVID tipped the balance in such a negative way. And I think the people who are studying nursing and healthcare workers traumas prior to COVID, I think the numbers are probably there saying, yeah, the traumas have been there all along, but COVID certainly has just tipped it all the balance, not in our favor. So stay strong, Tracy, and I think loving the nurses you have is already pretty great, because, well, it's kind of all we can do.
That's
joke
great
that
advice, Michelle.
Thanks.
Yes, please finish your sentence. I didn't mean to cut you off.
It's okay. Nurses, we create nursing care plans for our patients. It's kind of, if you're a nurse, you know what I'm talking about, that's what we do to sort of, we create a nursing care plan. And I have this wish that as nurses, we can create a nursing care plan for nurses that we can figure out, because our job's so unique and it's so misunderstood. We're not represented in media. People don't understand what nurses do. I feel like only nurses understand just what we do, because we're there. Anybody can follow me around for 12 hours. I welcome you. Please come. I'll try to help you understand what nurses do. But I really would love to see us be able to find a way to care for ourselves, because our problems are pretty unique in our environment, and our challenges are unique. That's it.
I really hope that some of the recommendations that Andrea had shared earlier can be like a nurse's, like a plan that you're talking about, a care plan. I am running just a couple of minutes late in our agenda, but I do want to close this panel, which honestly, I could keep listening to you for so long. I know that you have so many stories and experiences that are very illuminating, but I don't want to seem trite, but I do want to end on some sort of a positive note in terms of, when we started our panel, we talked about what you love about the job, and then we talked about the immense hardships that you face every day. And Krisha, you mentioned, you just have to do it. You just have to deliver the patient care. You just do it. You hug your, colleague, and you just keep going. So I'm wondering briefly if everyone can mention what is the one thing, or what is a thing that does keep you going, that can recharge you reliably so you can continue to work. And it's in the spirit of the advice for Tracy, I would love to hear from all of you one thing that does that for you. I see Krisha is thinking, so I'll leave her for a
Yeah,
moment.
I'm gonna be thinking. Yeah.
Yeah.
It's like a deep, dark dive. Sorry.
Jennifer, would you like to start?
Sure, I can start. I think one thing that keeps me going is that when patients are at their most vulnerable, when they're sick and in distress, they need someone to be there, to be that calm, reliable person. And even though sometimes we don't feel that way, we're struggling too, and we're working with limited resources, but the patient still needs someone to be there for them that can help them navigate the system. And at the end of the day, that's our job. We need to help people. We want to help people. That's why we came into the profession, whether as a doctor or nurse or any other healthcare provider. And that's what we will continue to do. And that keeps me going, because no one else can be that person for that patient in that time. And, it's just an honor to be in that role.
Thank you. And Michelle?
I think when I spoke of what I love about the profession, it's still there. All of what I spoke of is still there. It's not gone. And so it's fracturing, but it's not gone, and it's still there, and it's still what brings a lot of joy to all of our hearts, that ability to be a team that comes together and helps someone who's in distress, who brings our incredible critical thinking skills, our incredible scientific understanding, our hands-on technical skills. When we can do right by our patients, it's a very glorious moment. And I think those still happen for sure. And they're still pretty rewarding moments.
I echo the same as Michelle and Jennifer. What keeps me going is a lot of coffee and a lot of, self-talk that like, you can do this, you were put in this earth for a purpose. And it's true. It's true what Michelle said. It is a bit fractured because now I see it in a different way now. However, the only thing I can do is do right do right by your patients, make your own difference. And that's what keeps me going. I'm just like, I'm here to do my job. I'm here to take care of this person and this and during this shift, and that's my responsibility, and I will take care of them to the best of my ability. And yeah, because there's now, for me, I no longer have trust with the system. I'm not very, I don't trust the system. I don't think it works for any of us or for the patients and for their own health and safety. So I have I'm quite cautious. I'm always, it's terrible now because I'm more like a kind of like a cynic now because I don't trust it. But it doesn't mean that it doesn't always, it's not always negative, it's always positive. So what I always think about is, my patients being discharged, walking out of there, and being, like having done something to promote their own health, and making a really, and also I find that they've also spoken to us and really understand, like, you guys are really short. You guys are super short staffed, and they understand and they give us, and they empathize with us, and they say, I'm so sorry, I'm not going to try to call, but I just need this one thing. And I'm like, it's okay, it's fine. You need something, but they're really, and I appreciate that. I really do. And I also appreciate them not voting for Doug Ford, but that's usually how I do it during campaign season. But yeah, and yeah, sharing a laugh with them. I don't know if you guys notice, I really like to laugh, and that's one of my thing, is just making people laugh and making my patients laugh. And that's what keeps me going, is at least like during their time of need, I can always at least try to make them laugh, and I put a positive spin in a negative situation.
Your patients are lucky to have you. And I say that to you, Krisha, and to you, Michelle, and to you, Jennifer. And I want to echo the feelings that are coming through the chat. There are many hearts and many thank yous. I wish I could say thank you in an even bigger way, but just, I hope you can see in the chat that people are so appreciative of the space, of the stories you've shared, and that you brought your whole selves to this conversation, which I'm sure was not easy. So thank you very, very much for today. Thank you. And I would like to tell everybody who is here, please take this opportunity to have a very quick break. It's meant to be 5 minutes, but maybe we'll even shorten it to 3 minutes. We'll see. This is your time to grab a glass of water if you need. Also in the chat, I encourage everyone to drop one word to just say how you're feeling at the end of that panel. It would be really nice to connect or feel that connection with everybody else who's here. How are you feeling? How are you doing? So we'll be on a quick break, and then we'll come back with another panel with healthcare researchers on this topic. Thank you very much. Hello, and we are coming back from the break. Thank you so much to everybody who is keeping the chat going. I really enjoyed reading the comments, trying to stay on top of them. But I'm so happy to see how people are sharing what that last panel felt like, to be a part of that conversation, to be hearing the conversation. A lot of feeling connected and recognized and inspired and empowered. So thank you, everybody who is listening and participating. Now we are going to go to another panel this time with researchers. This panel is on risk and mitigating factors of moral injury and moral distress in Canadian healthcare providers during the pandemic. So I'd like to introduce Maë Gilbert-Ouimet in Quebec, Michelle McCarron in Saskatchewan, and Margaret McKinnon is coming back for this panel as well. So you three will be bringing your research to this conversation, and I'll go to each one of you one at a time to describe your research a little, and then we can open it up for some conversation. But first of all, I just want to know if anybody has a quick reaction to what you heard in the panel before the break. I see Margaret nodding. Maybe you would like to start.
Thank you, Hannah. And, I don't think we can say strongly enough to our healthcare workers who spoke today, thank you for your courage. We see reflected in the comments just how much people are hearing heard, recognized, valued. And I think giving people words to describe experiences are very powerful. So hearing about moral injury, often people say it helps me to realize I'm not alone, that others are experiencing this. And we're hearing that in the chat today. It also is a reflection of the incredible service that nurses, physicians, occupational therapists, environmental service workers, admin assistants, everyone in the system has given. I can tell you that during the pandemic, when people were talking about the utility closets, that rang so true. I was in a COVID unit for a day and a half, and I actually sat in the utility closet while people changed their masks to provide mental health care, because it was the only time those healthcare workers had to receive care. So I just feel that we cannot thank you enough, to all of you in the audience and to our panelists, for sharing your stories and for your courage and your sacrifices. So thank you.
Absolutely. And Maë or Michelle, would you like to provide any reaction to what we just heard?
Yes, well, like Margaret said, I want to thank you for speaking up, for being there with us today. I am an epidemiologist. I work on stress at work among various populations, but the project that I'm going to speak to you about in the next minute was my first experience with moral injury. And what I was not planning to say was that I cried a lot when I was reading after the interviews that I performed. It was really hard, and it's kind of coming up when I hear you speak. So it's a very humbling experience. I admire you, and I want to thank you.
And I just want to really echo what Margaret and Maë said about thanking the panelists, the healthcare providers, for sharing your stories. It's really so powerful hearing these stories from you in your own words and how this experience has impacted you. And I had the same experience when I did research in this area, that it brought tears to my eyes, honestly, doing the interviews and then reading through transcripts after, because just the amount that people were impacted by their experiences providing healthcare in those very trying times, and the sustained impact it was having on them, the cumulative impact was really powerful. Yet they kept showing up day after day and still doing this and trying to provide the best care possible for patients. And I heard those same themes echoed amongst the healthcare panelists today, that strong commitment to caring for patients really, really comes through. So thank you for that.
Yeah, and I would like to add that for the panelists, I was saying that there's almost no way to verbalize how much gratitude you feel when you hear the stories communicated. So please know that these are the kinds of things we think about later. As Maë said, part of your research, your stories really stay.
I'm sorry, I'm just going to do this now because we've been talking for so long, the batteries have died. So as long as you can still hear me, yes. I want to get right into the research that all three of you are bringing to the panel. Michelle, can we start with you? If you want to briefly tell us about your research and what types of stressors people were describing to you in terms of their work in healthcare.
Absolutely. Thank you, Hannah. And just before I get started, I do want to acknowledge that I'm speaking to you from Treaty 4 territory in Regina. So my team and I did a qualitative study, interview study with healthcare providers in the summer of 2021, wanting to learn more about their experiences of providing healthcare during the pandemic and the stressors that they were experiencing in the workplace and the moral distress and experiences of moral injury that arose from those. So we conducted this study with 37 frontline healthcare workers whom we interviewed across Saskatchewan. It was supported by an IDEAS grant from the Department of National Defense. And we had the opportunity to speak with people in a variety of roles. So nurses, doctors, people in various types of therapist positions, hospital food service workers. So really trying to get a broad spectrum of frontline healthcare providers. And we also spoke to people from across the province. So we had a really good mix of rural, northern, and urban healthcare providers and in a variety of healthcare settings. So in hospital, long-term care, or public health, for example. So we had representation from all of these different parts of the province and people and working in all sorts of roles. Yet there were a lot of types of workplace stressors that people were bringing up to us consistently when they were telling their stories. So some of these were pre-existing the pandemic and were exacerbated by the situations in the pandemic. So things like increased overtime, the regular communication barriers that can arise when you're working in a large healthcare organization, and particularly when directives were changing so rapidly, particularly in the early days of COVID. The stressors that come with working in a fast-paced, very high-charge, high-stakes environment, and not always agreeing with some of the decisions being made by leadership about the different directives that they had to follow. So there were workplace stressors like that, but there were also some workplace stressors people described that were really novel for them, arising from the pandemic. So things like staff redeployments to ensure that coverage was in areas of greatest need. Things that really they felt was impacting the quality of the patient care that they could provide. So reducing or temporarily shutting down entire services, delaying surgeries. So if they weren't emergent, then they were typically delayed in a lot of cases. And people said that, these might not be seen on paper as urgent, but they still really impact the quality of life of patients. And having to hear how much they were suffering because of these delays was really taking a toll on them. And then there were things like enforcing visitor restrictions. And this is one that came up over and over again. And particularly, I was hearing lots of stories from people who were working in long-term care settings. And they kept bringing up the experiences of working there at Christmas time in 2020. So these interviews were conducted in the summer of 2021. And it was really heartbreaking for people to have to keep residents from visiting with their family members. So they understood the logic behind the rules that need to try to prevent the spread of COVID, but people kept telling me that, there's that physically protecting residents, but then what about the psychosocial impacts and the impacts to their overall quality of life and to their families? And sometimes people wondered if the trade-off was worth it because they saw people suffering in other ways so much. So sometimes people would find some creative workarounds for the rules and try to enforce the spirit of the law, if not the letter of the law per se. So there's a story one time of someone that said that, they didn't care if they were going to get in trouble for this, but they weren't going to keep this family from seeing the patient. So they had the family stand in the doorway in the foyer. So there was still the inner doors there. They still had the resident physically distanced, but they were at least able to speak to each other and see each other. If people dropped off packages at that time, they were supposed to hold them for 24 hours before delivering them, just in case, because again, you know, not sure how much could be transmitted from passing packages along. So there was one person who said that when families dropped off packages on Christmas Day, they weren't going to withhold those from residents on Christmas. So they took down sanitary wipes, wiped the packages down thoroughly, and delivered them. So trying to find those compromises. So there were these stories, these examples of people who were experiencing these moral dilemmas about, you know, do I do what I feel is really right for my patients and residents versus do I follow the directives to the letter? And people were really struggling with what that brought up for them and wrestling with those types of decisions. So that was a really big overarching theme there. So maybe I'll just stop it there for now so I can let other people have a chance to speak, but I'm sure we'll come back to this at some point.
Yes, thank you, Michelle. And I would like to go to Mae because you also did research on moral injury based on interviews with healthcare workers in Quebec. Were you hearing a lot of the same types of stories, or can you tell us about the stressors that healthcare workers were describing to you?
Absolutely. Thank you, Anna, and thank you, Michelle. Yes, there are definitely overlaps between what we shared, what we observed in our research. So a little context for you to understand what my team and I did. So we led a research project among 572 frontline healthcare workers during the third wave of the pandemic, so also during the summer of 2021. The project was also funded by the Ministry of Defense of Canada. Participants, there were two phases of the study. So participants first completed a quantitative questionnaire, mainly focusing on psychosocial stressors at work and mental health problems, including moral injury. And a subgroup of them then were invited to be involved in qualitative interviews to get a deeper understanding of the events and emotions that led to moral injuries. So in the quantitative component of the study, the stressor that I really want to speak about today is the stressor that had the highest adverse association with moral injury. It was the lack of ethical culture in the workplace. It's not surprising. In our sample, participants working in a setting lacking ethical culture had 5 times more risk of moral injury compared to workers benefiting from a strong or adequate ethical culture at work. So you might wonder, what are we calling a lack of ethical culture? So we asked a series of questions like, in general, unethical situations that arise at work are not discussed transparently with those directly involved. We also asked, in general, unethical situations that arise at work are not constructively presented and openly discussed with the rest of the workplace. So we spoke about debriefing, the importance of the debriefing with the team. So in qualitative interviews, to give you an example of a verbatim, a participant reported, if I think about the profession that I'm doing, a value that they told us so much about during our university studies was that if you're doing something, do it right, do it neutral, but do not harm. By obeying the directives, I considered myself doing harm. So it kind of resonates with what we heard before the pause. So this testimony was aligned with other events that were reported by participants. Events involved being unable to provide appropriate care, even basic one, because of lack of resources. We were also told about the inability to apply security measures and directives related to COVID-19, being unable to ensure your own security, but also patients' safety, and not being adequately supervised. And this was reported a lot when speaking about movements from units to units and having to sometimes switch specialty and not being adequately trained. So these events were linked to a moral injury through emotions like frustration, anger, guilt, shame, helplessness, feelings of worthlessness, isolation, or deconsolidation of the work collective, feeling of injustice and betrayal, like Margaret spoke about, feeling of incompetence, sadness, and also sometimes loss of meaning. So I'm going to finish my short intervention about the values that were reported as hurt. They reported that professionalism was hurt, patient and self-safety, compassion, kindness, and humanity. So I'm finishing this little testimony by reiterating the importance of ethical culture, at least in our research project.
Thank you so much for that, Ma'e, and for describing what an ethical culture looks like, which it sounds like a lot of communication and understanding, like recognizing the humanity of the people who do the jobs that we need done. Margaret, I would like to turn to you now. Earlier, when you were speaking with us, we talked about moral injury, what an injury meant. I would like to talk about have you talk about the neuroscience around trauma. Can you describe what effect moral injury has on our brains?
Yeah, I certainly can. And Hannah, if you don't mind, I'm just going to follow up a little bit on some of what was said already and then turn to that question, if that's all right. I think what we've heard from Ma'e and Michelle is very much what we also heard across the country. We conducted 134 qualitative interviews and heard very similar themes, which I think speak to those experiences that bind Canadian healthcare workers together. And we know that one of the most protective factors against the development of post-traumatic stress disorder in the face of situations like this is social support. So being able to speak to one another, to hear one another's stories, to provide empathy and caring and support. And so I think part of what our job is in the Canadian healthcare system right now is to recognize the organizational and systemic factors that are impacting upon healthcare workers and to provide the supports to bring the system back together again, to bring the family back together again, essentially. We've done similar interviews in public safety personnel, which we'll be holding another symposium on later in the year to talk about. But I also want to say that when we looked at what are the factors that are driving departures from the healthcare workforce right now, and we heard a lot about that from Michelle, from Krishna, and also from Jennifer, we found that moral distress is what's driving the decision of 1 in 2 healthcare workers who are currently considering leaving their clinical positions in Canada. And so when we look at the number one factor that's driving that, it is the moral distress in the situations like Ma'e and Michelle have described here. And so I think when we think about the peril that our healthcare system is currently in due to healthcare shortages, due to rapid staff departures, and so on, we really do need to target, to know about these experiences of the moral distress, to address the organizational and systemic factors that underlie some of this, and to provide the individual level supports to healthcare workers and all healthcare workers, be that food services workers, occupational therapists, nurses, physicians, everyone in the system who's providing this service. And the simple value of saying thank you, I think, cannot be underestimated. I have been in basements of hospitals saying thank you, and to see the look on people's faces when they hear thank you for your service, because this is service and your sacrifice, and to say thank you. Those simple words are very powerful. And I think the more we say it, the better. So we want to say it again publicly here today. When we talk about the neuroscience of trauma, we certainly know that there's a saying in trauma that the body keeps the score. And so among people who have experienced trauma, for example, we see higher rates of heart disease, obesity, diabetes, and other forms of cardiovascular risk factors. We also see changes in brain functioning and brain structure. And so we can see differences in the patterns of the way that the brain works together in concert. And we can also see what's called essentially a loss of some of the tissue in the brain with repetitive stress or even a single trauma in some cases. And so what we do, a lot of the work that we do is focused on helping to help with some of the impacts of those changes in the body and in the brain. With moral injury, in work that we've done, led by Ruth Landius at the University of Western Ontario, and with some graduate students that we co-supervised and postdoctoral fellows, Chantal Lloyd and Braden Turpo, we actually had military members and public safety personnel who had PTSD recall events that were associated with moral injury for them. So that could be, for example, being in the combat theater and seeing a baby going down the river and being powerless to intervene. That's the description, that's an apt description, or being a first responder who is not able to go into the lake to save the person because the rules of engagement say that they can. And people talk about these moral injuries and the consequences for their lives, just like we hear here with healthcare workers. And what we found is that when these public service personnel and military members recalled these events, we saw areas of the brain involved in disgust light up. They were active. So that feeling in your stomach like you've been punched in the gut. There's a brain region called the insula, and that region was very, very active when these memories were recalled. We also saw that areas of the brain, so one is the dorsal, it's called the dorsal anterior cingulate, was sort of the middle of the brain. That's associated with shame and guilt. And that brain region, again, was very, very active. And the brain was trying to compensate for this. So the frontal part of the brain, which really helps to regulate our emotions, it was trying to dampen down to feel those feelings of disgust, the shame and the guilt, the feeling of moral judgment. The brain was working overtime to try to dampen that down in a protective way. And so what I would say these stories tell us is they tell us the impact of trauma and situations like moral injury on the brain. This is an injury, like all other injuries, and there's so much shame and guilt that surrounds mental illness. But here we see the changes to the brain that occur, and we can show it in a picture. This is what's happening. So I think that helps to, again, explain the experience, and what happens in the brain makes complete sense in terms of people feel like they've had a punch in the gut. And this lingers after the incident itself. These are scans that could be taken, 4, 5, 10, 15 years later, and we're still seeing that punch to the gut in the brain.
What I love about neuroscience and the work that you do, Margaret, is that when you see that injury and the evidence of it, I hope that it does take the onus off of individuals who are thinking, why can't I cope? Yeah. In fact, we are all wired in ways to react to these situations. And it's partially why your work is so important. In the few minutes we have left, I would like to ask this whole panel about what you would like to see workplaces do in order to lessen the impact of moral distress on healthcare workers. If we have heard from Michelle that moral distress is a part of the job for nurses right now, what can workplaces do to lessen the impact? And I would also like to ask about what you're seeing in terms of hope for how workplaces are changing. So we'll just start, we're going to cram a lot into the last 5 minutes, okay, everyone? So I would just like to start with what you would like to see workplaces doing. Maybe Michelle, would you like to begin?
Sure. Well, I do want to say that I think it's encouraging that workplaces are having this discussion more openly. So we would see, for example, in internal newsletters that would come out, that they would be advertising the mental health support line for staff, telling people what sort of EFAP resources were available for mental health supports, and including kind of mental wellness tips. Now that's where it sometimes kind of fell flat for people that I spoke with in the interviews. And that's where I think we could maybe do a better job of increasing supports for people, is engaging the frontline healthcare workers in determining what types of mental health supports are going to be most meaningful for them. So, I would have people telling me that, it's all very well and good to provide tips on healthy sleep hygiene, but if they're working so many hours and then have family to take care of, that they don't have the number of hours in a day to be able to sleep like that, then they're not able to implement those types of suggestions. So really engaging the frontline healthcare workers in helping to come up with the solutions for what is going to support them best in the workplace.
Mae, would you like to add to that?
Yes, thank you, Michelle. Thank you so much. As a result of our research project, we formulated recommendations, and I'm going to place them on the chat because I know that we are tight on schedule. So I'm not sure that everybody could see them, but maybe you can post them. So our recommendations are not one size fits all recipe, but they aim to heal the working environment. So we're not into coping mechanism. We really want to focus on the working environment and on building a climate of kindness and of psychosocial safety. They are grouped into different categories, and I'm going to just give you a few examples really quickly. First category is training. So we really think it's important to train the leaders to detect the first signs of distress or moral challenges in their employees, and to actively listen and support. Second key is communicating. So opening the gate of open, frequent, empathetic, and leader-led team discussions to build awareness and prepare for the situations that might or that will come up. Like Michelle said, having all levels of worker participating in the intervention efforts is crucial. And I'm going to end with prioritizing mental health. There are not a lot of resources in the healthcare, but we cannot keep on pushing back. This is a priority among the other priorities. So that's it for me for now. Thank you.
And Mae, thank you so much. I think you said that you had dropped the link in the chat, but I don't see it. So maybe if you want to try that again in the last few minutes, or as well, I'm hoping that Sangeeta can drop the link to the Healthcare Salute website and socials. And so afterwards, I hope that everyone here can follow up for further connection there. Margaret, can I end with you in terms of where you see hope for how workplaces are changing and incorporating these discussions in the workplace?
Thank you. And so we asked healthcare workers in the interview, what is it that you need? What would help you? And many of these healthcare workers said, we want people to know our stories. We want people to hear. We don't want to have to keep retelling them. And when we go for mental health supports, for example, that the person at the end of the line isn't crying when they hear our story. And that often happens for public safety personnel and military members. They tell their stories to a mental health professional and they end up comforting the mental health professional. And that's difficult, right? So we've been really fortunate to have funding from the Public Health Agency of Canada, a donation from Homewood Health, the Center of Excellence on PTSD, and the Canadian Institutes of Health Research, which is really hopeful to see all these agencies supporting this, to develop cultural competency or cultural sensitivity around the experiences of healthcare workers. And so with the courage we saw here today of healthcare workers who told their stories, and continuing work to really get that knowledge out to the public, to leaders, to policymakers, and to others. We really have the opportunity to provide supports that are culturally competent and what people need and what they're asking for, and so that they don't have to retell their stories over and over again.
Well, thank you so much, Margaret, and thank you, Mae and Michelle. And, you know, I can see in the chat that there's a lot of reaction to the research and the information that you've shared. And I also just want to thank every participant who has presented or spoken today, and especially to the hundreds of people who showed up from across the country to come and listen and learn and to participate in the chat as well. You know, Mae, I think you said this is a priority among priorities. I couldn't agree more. And I hope that everybody here has gotten something out of the symposium and that you can stay connected as well. So there was a wellness slide earlier with some mental health resources. I hope that that can be shared again here. And I just want to wish everybody a good day, and thank you so much for taking part. Goodbye.
And thank you to all of you for your service. We salute you.